let's get people situated. um, Chaitanya, can you help with this side and get people's attention back to the tables, please? Thank you. Thank you. Really appreciate it. All right. We are live back in the room and also virtually on Zoom. Thanks, folks. I hope everyone had evening snacks and tea. And feel free to get some boxes while you're on your way home later. Before we start off with the session, I want to give you a quick recap of what's happening in the next 1 hour. This is our final 1.5 hour of the day today. And thank you so much for hanging out with us, attending all the amazing panels we had. We have two things, major things happening now. One of them is a session with Dr. Kathleen Lin about female reproductive health. And right after that, we have an amazing, amazing music concert happening for everyone in this room who showed up today, who stepped forward. And right after the music concert, we have a special announcement coming up along with some picture time together as a group. So I would encourage everyone to stay here with us. And before you go, please collect the thank you notes from volunteers. Volunteers are going to be passing them around during the last 1 hour now. Please stay in touch with us, and you'll find ways on that thank you note to stay in touch with Vahati as well. I'm going to announce that later. So having said all of that, let's start with the panel discussion we have coming up, the topic that's very crucial, very important for all the women out here, but not something that we talk about, especially not in South Asian community. I feel confident in claiming this because I'm part of the community, and for years and years, I've never paid attention to this myself until coming across the caveats and the, how do I say, the gaps and challenges of migrating here as an immigrant, then trying to think about your career, going through all those phases, putting away your family planning aside for a while, and not knowing what are the gaps and caveats that can happen in future. So with that said, we chose this topic very carefully and very intentfully because we wanted to make sure that with Bahati, we don't just talk about career, we don't just talk about professional growth, we talk about personal growth as well. We talk about women's health and the entire well-being aspect of it. So because we emphasize on all of these diverse walks of life and diverse ranges of topics we touch on, we are inviting Dr. Kathleen Lin today from RMA Fertility Clinic, who's going to be talking about a topic on feeling like a reproductive rock star, the do's and don'ts of egg freezing. Again, a topic not many of us can speak about right now, but we all want to know about. Thank you, Dr. Kathleen. I want to introduce her real quick. With over 20 years of experience in reproductive medicine, Dr. Lin is a board-certified solo fertility specialist at RMA, Reproductive Medicine Associates. She's guided thousands of South Asian immigrant women through their fertility journeys, offering expert insights and practical advice. One of the things we were specifically looking for when we designed this entire program were experts who have experience working with South Asian women in US and who know what are the questions that come up in our mind, what are the gaps in our understanding coming from the cultural background we come from, and what really helps this diaspora make advancements in that aspect. Dr. Lin has established the Division of Reproductive Endocrinology and Infertility at the University of Washington and was named the best doctor in the region for infertility and endocrinology since 2018. So without further ado, I'm going to give the mic to Doctor and let you educate us on female reproductive health.
First of all, I want to say thank you to Vahati. This is amazing. This is wonderful that you all have this community to come to and that it's pulled together with all these interesting topics. I definitely think that the brainchild behind this, the organizers, Sarabi, Sandhya down in California, and all of you out there, It's this energy of that magnetizes you together will hopefully be able to stir up all kinds of information so you don't feel as alone. So I'm going to start by first introducing my team. So we get together also a couple of times a year. It's a wonderful team of people. And when I built the practice, what's really important to me and in the staff is that we really get to know our patients and their story. We spend a lot of time with our new patients, almost an hour or more. We want to hear from about what life is like, what are the challenges, what does it mean to come to a fertility clinic, because we feel that we're really inserting ourselves into an important part of that patient's journey. We have two locations. One is right here, which is 2 blocks away. You could probably throw a stone right into the window of our office. It's right in the building next to Nordstrom on Olive Way, the medical dental building. We're on the 5th floor. And last year we opened a facility in Bellevue across from Seattle Children's Hospital, very close to Overlake. So it's super close to kind of the junction of all of this. We now have a beautiful facility, lots of capacity to take care of patients so that the entire fertility services are all under one roof. And so I'm really glad I don't have to drive all around. But I am the only physician and have been the only physician. And you guys might wonder, how do you actually get to this point? There's some young ladies here. I just met a lovely 22-year-old with an MPH interested in this. I see young women maybe thinking about a career. It's a long career, a long way to get to where I am. It starts off with university, medical school, residency. So I was mostly East Coast. At Cornell was where I did my OBGYN residency. And then I did fellowship at University of Pennsylvania. So it's a 4-year training program after med school, plus that 3 years of fellowship training, where we learn about fertility medicine, the research techniques that are involved in fertility medicine. And I have a specific interest in male factor infertility. So I went back from Philly to New York and I couch surfed so I could follow the chairman of urology around and do testicular sperm extractions and take care of men. With all that being done, University of Washington brought me out to start their division. They didn't even have that kind of clinical practice for their patients, and they needed it for their residency education. So I came all the way across to beautiful Seattle to get that program started. But after a while, I realized it's too big. Patients need to be able to call and talk to their doctors and not go through 7 different layers before they can find their provider, especially if they're calling because they're having a miscarriage or they're having scary bleeding or they're just questioning their medicine. So I actually left the big university and I started a super tiny clinic that is now still under that philosophy of trying to reduce the layers between the patient and the provider. Many of you have come from different countries. You guys are new to this place and you need to be able to trust your healthcare provider. You need to it's so complicated to even get to speak to your doctor. Why? As a physician, I think it's much easier. I don't have to go to the medical record. I know a lot about my patients because I actually spend time with my patients because I like being with people. That's why I went to medicine. Now I joined a very large network called RMA. Globally, it's called the EVRMA. And they're really the reason why we were able to build such a great facility out in Bellevue. And all their support, their data, and their expertise is behind all the medicine that we provide. Okay. So fertility medicine, who uses it? What is it for? Traditionally, when I was in fellowship, it was really for the infertile couple. The older couple, the couple with miscarriages, maybe male factor infertility. The idea of preservation or freezing just wasn't there yet because the lab wasn't as good. We couldn't freeze individual sperm, we could freeze sperm, but we could not freeze eggs with that kind of fidelity. Eggs were not able to survive the freeze thaw. So nowadays, what can we do with all this flexibility? We help lots of different families form, certainly the LGBTQ community. We help when there are ages that are quite different between partners, a much older female partner with a younger male partner, for example. We use lots of third-party reproduction, egg donors, sperm donors, embryo donation to help families grow. We obviously have our traditional infertility couples with the diagnoses that we've learned so much to help take care of. We even have this idea of family balancing, families where they have children of one gender and they just really want to experience life with children of the other gender. So that's family balancing. But for you all, the majority of you having a free Saturday to hang out and get to know each other, maybe you got some things that you're thinking about doing. You're building your careers, you're away from your families, and you're busy. So for this aspect, I'm glad that it is now 15 years after my fellowship, and we have become so good at freezing tissue. Egg freezing and embryo freezing. We now use a technology called vitrification, which means turning something to glass. That means that we're able to freeze cells by removing most of the water content from the cells, because that's actually what was destroying the eggs early on. So when we were able to learn how to do that, the eggs and embryos can shrink down and expand. We got busy people doing all kinds of things, young couples just getting together and they're not ready to start a family yet. We've got busy people going for their careers or thinking about building a business. I really enjoyed seeing what some of the other topics were today and networking with each other. So the New York Times did a series of articles about the idea of fertility preservation, and I love this quote. It's a concept called biological liberation. Because technology caught up with what women want to do, this quote comes from a young lady that froze her eggs early on when egg freezing became non-experimental. So that was about 2012. And that's when all the tech companies started picking it up. First it was Facebook, then other tech companies started offering that. And she said, I approached everything differently, knowing that those eggs were there. I was calmer about my dating life, and I wasn't panicked about my biological clock. I felt really proud of myself for being a patient. So that was in the New York Times, and a series of articles came out, and it really helped mainstream people understand that this technology exists. So I want to teach you a little bit about why it's biological liberation, why it's fertility preservation, okay? So how many eggs are we born with? Does anybody know? How many people think we're born with unlimited eggs? 1,000 eggs? 1,000,000 eggs? Yeah, about 1,000,000 eggs. We have more eggs before we were born. This is birth. And then slowly, over time, they do decline. In fact, it's not that slow beyond age 35 because this is a logarithmic scale. So I would probably have to stretch this out for half the length of this building to show you what's going on with our ovaries. If you look at a real ovary, a snippet of it, right here in the section 1 includes all the eggs that are in reserve. These eggs are quiescent. These eggs don't respond to anything. And that's how come we have periods and ovulations all through our life for 30 years until we have menopause, typically around 50. But every month, there are crops of these eggs that start to get ready, and they start to prepare to be competitors in a particular month. So you can see that they're starting to get bigger. They get the cells around them to become responsive until finally they look like that structure up there. And with that little bit of fluid in there, we can actually see those follicles. We call them follicles or egg sacs when we do exams on women. We can find the ovaries and we can count these active eggs. That tells us a little bit about where this person stands. If this is the median, and somebody comes in at age 30 with not that much, that person's trajectory needs to speed up. And so we do have the ability to measure ovarian reserve. It's not necessarily fertility, because fertility is really defined, as I was saying in the hallway to someone, whether you're having a baby. Because you could have 2 eggs and try that month with a wonderful partner and have a baby and never know what your fertility status is. And infertility is defined as if you try for a year and nothing happens. Now, that's, of course, if you have regular cycles and intercourse is happening productively and at the right time. So we've got to make sure that we educate our patients on that. And then there's this really hard thing to measure. Like, we can measure number, we can measure hormones coming from those follicles, but we cannot measure what's happening inside the egg. This, in that number 5, you see there's kind of a clump of dark stained area. That's DNA. So our eggs actually have too much DNA our whole lives. And when they go into competition, the first thing they have to do is split that. And then at the time of fertilization, they got to split the chromosomes again. There's a lot of splitting going on. And as we get older, the splitting gets harder. So this is the little apparatus, we call it a spindle, of a 20-something-year-old. You see how nice and even you can see it? The chromosomes are all in the midline. So when the signal comes for ovulation, the signal comes for fertilization, the chromosomes separate faithfully. This is a spindle from a 40-year-old's egg. So it's pretty chaotic looking. The chromosomes are all over the place. And so that signal coming from fertilization, from ovulation and fertilization causes erratic numbers to go in and out of cells. And that is the main reason that people have miscarriages and infertility as we age. We can't measure this. We can measure numbers, but oftentimes they go hand in hand. And especially when you're younger, both go hand in hand. So think a little bit about that. Okay, so what is actually the ideal woman? This was little circles in front for egg freezing. There really isn't any. During COVID, our small clinic, I had to shut that down, or at least for patient services. And I had to really think about which kinds of patients do I want to take care of during this time. And so one of the categories was, of course, 39-year-olds and older who had had an unsuccessful IVF cycle, who was miscarrying, single women older than age 38 that needed to have sperm introduced in order to conceive, and they were aging, and egg freeze patients older than age 38, because those patients really couldn't wait. And so any age is fine for egg freezing, but the graphics of this originally was that this was darker, lighter, 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 and lighter meaning just the less effort you have to put into it, the less number of times you have to go and try to freeze your eggs. Because when we freeze eggs, we actually don't know whether that was a cycle that the patient was going to have a baby with. So the more times we're able to do that, the greater the chance that we'll be able to find the best egg. When we're younger, it's probably in that cycle. When we're older, we may have to do it a couple of times because we don't get the chance to fertilize those eggs and see if they actually make babies. And yes, so it doesn't really matter, except I think there needs to be some discussion if you're older than age 41, 42. You got to go through the numbers with the doctor. You got to see how you tolerate the cycles and whether it's worthwhile to continue. I find that oftentimes there's never a one-size-fits-all. So if you do seek help in thinking about fertility, just remember everybody's different. Everybody has different goals. And then when you walk away from a particular process, you want to know, well, what can I rely on? Like, how do I think about this? Because the more realistically you think about this investment, the easier it will be for you to come back and utilize it in a realistic way. Okay, So a little bit more like when you guys come in, if you're interested in egg freezing or figuring out what your fertility status is, or some of you may very well be struggling, like some of the patients that I showed in that first picture. And so coming in, having time to speak with me or speak with, I have two nurse practitioners who I've worked with for 3 to 6 years. We're very, very closely connected. We discuss our patients all the time. And I'll know your stories even if you're not the one that actually comes in for the new patient appointment, because we review decisions together every day. So even if I'm on vacation, weekends, it doesn't really matter, because I really love that continuity of care. In our EMR through RMA, because it's such a robust system, we actually can put your age on we can actually put your AMH, which is the hormone that we can measure from the crop of eggs that's competing. We can then look at the ultrasound that we've just done and see how many of those little follicles we counted. And we're able to actually calculate the number of eggs that we would expect for you should we go through egg retrieval. So for this individual, they got an AMH value of 3, which is pretty normal for women less than age 35. We want to see the hormone output from the follicles to between 2 to 4. In Canada and other countries, it might be in picomoles, so we have to do some conversion. But here we use nanograms per deciliter. And then we can definitely take a look at the ultrasound. So ultrasounds I find with women that are not necessarily used to going to the gynecologist, like that can be a little bit nerve-wracking. Like, what do I do? Like, I just came in the clinic, they just told me to take my pants off and my underwear off. Like, what's going to happen? So that was the first thing that I realized, that it's really invasive. They've never met me. They've never met Taylor or Paulina. And so that's why we really try in that new patient appointment to introduce ourselves, to come in and out of each other's new patient appointments so you can see who we are. We also have a real sensitivity to not just push our way through the appointment. We quietly and calmly take our time, and we also ask help from the patients. Would you like to help us put the probe in? Are you virginal? Because if you're virginal, we need to talk about how to do ultrasounds with a full bladder so we can look for the ovaries. Or frankly, maybe you're not virginal, but you just don't want vaginal ultrasounds. We have lots of different ways to get the data that we need. And so that's the personalization of the care that I feel very, very committed to. A lot of our patients too have sexual and vaginal discomfort. And so with that, we've developed different techniques to help those patients. We know how some of them may need a little bit of desensitization before we insert the probe. We might have to pre-medicate with some numbing medicine or some dilation or some other techniques. But what our goal is to provide a very safe environment to explore those options. And it's also very helpful for, healthy sexual life if that happens to be an issue. At our fingertips, we have a wonderful referral sources for our patients, because we do get to know them so intimately, to help with these pelvic floor dysfunction as well, and bring some ease to maybe an area that seems kind of scary. Okay, what tools do you have if you're not a patient at RMA and you just kind of want to poke around and see? In this website, you can look it up. It's called MD Calc, and you can look for the egg freezing counseling tool or the calculator. And here, using a set of data from a clinic that did egg retrievals and looked at the probability of live birth from the number of eggs, controlling for the diagnosis of the infertility. So they chose only women with blocked tubes or male infertility, things that weren't actually significant infertility issues that could affect ovarian reserve, the most like your egg freeze patients. If I put in age 34, and I say, okay, I've got 15 mature eggs frozen for this woman, which might mean that I've retrieved 20. And of the 20, we only have 15 that are mature, which is pretty awesome if you think about it. We were only supposed to get one baby. We had 15 competitors. So that's what we try to do with our medicine that we help our patients learn how to take. So 34 years old, 15 eggs, gives us an 83% probability of at least one live birth, assuming a 95% survival of thawed eggs, 50% of having 2 children, and 22% of having 3 children from 15 eggs frozen at age 34. If you play around with the calculator, these numbers plummet as we age, just because both the numbers of eggs and the quality of the eggs are declining with age. So for my 35-year-old and younger women, like, please do this, because hopefully it means that we can do this only once. But if you're older, please do this. It means that we may need to do it a few times, but it allows you to consider having biological children in the future. Okay, so what does it look like in the lab when we freeze eggs? I purposely don't want to spend too much time showing you guys injections. I know that can be a little bit hard, but the rock star part of it is that we really try to help our patients learn how to do the injections properly. There are a lot of different videos out there, and I always tell my patients, if you need help, you bring your medications in, and you sit there, and we'll watch you do that first injection. We won't do it for you, but we'll be there in case you need it. And so occasionally our patients want to do that, and I especially extend that to the egg freeze patients because I know they're typically alone. Although some of my egg freeze patients have turned this into kind of a party, like a few of them are doing it at the same time, so they all kind of get together and do their first injections. I think that's kind of fun. And then they do need to come in for monitoring several times in 2 weeks. So we get to know, it's like speed dating. We get to know each other really, really well over 2 weeks' time. We do blood work, ultrasound, again, how you like to do the ultrasound. And then at lunchtime, I get together with the team and we make those decisions. And it might be, tonight is so-and-so's time to trigger. And so 36 hours later, we'll meet in the operating room or the procedure room, and I'll do the egg retrieval. So I've done egg retrievals for all my patients for the last 10 years, probably close to a couple thousand. And nowadays, we use a system called Matcher that's very unique to RMA. So not only are we eyeballing your name and your date of birth, making sure all that's correct, we have now barcodes that carry across dishes, across devices that hold your eggs, as well as identify the tank location where your eggs are. Okay, so this is an electronic ID system that we have, and we double eyewitness everything as well. Once the eggs are actually frozen in that vitrification technique, and about 2 to 3 eggs per device, thereby giving you flexibility later, you might want to thaw 10 of them, keep 5, or you may want to thaw all of them. They go into liquid nitrogen, which basically keeps them biologically stable. They don't change for however long. So we like to joke with our patients, we're your first babysitters. We're like your aunties. Like, if you move out of the area, please let us know where you go, because we are babysitting for you. And so this is a really secure system that we have. We have a room that's fingerprint protected, that's entry is only a couple of people in the clinic can get in the back. We have liquid nitrogen safety systems, 2 alarms. And so we take the storage of tissues very, very seriously. And actually, this is what eggs look like. So this is, my patient had an egg retrieval. I used to take a lot of pictures and then like message them in, although I realized a lot of the eggs look the same. But this is for real what they look like. They kind of look like when you actually have that chicken egg and you've got that thing kind of hanging in the egg yolk as you beat it up. But the egg itself is this dark little spot, and the cells around it are the cells that you saw in that follicle, and they're the ones that take the hormones either from your brain or they respond to the hormones that you're injecting. And so helps translate all that message to the egg and mature the egg. So some of the dish has little bubbles. And then what are these doing? These are little pipettes that immediately after egg retrieval, the embryologist will start to trim down the cells around the eggs because we want to isolate the egg into a single cell so that the freeze can be really, really solid. And so that's what they're doing, mechanically cleaning them. They'll chemically clean them and then they will freeze them. And we freeze only the mature eggs because those are the ones that kind of made it on time. The ones that are immature, they're not ever going to fertilize very well. And we currently don't have the technology to really mature them effectively in the lab. Okay, so then the eggs are frozen, and then people are off building their businesses, traveling the world, finding the right partner, waiting for the right time to have their children. So then what happens in the future? When the eggs are thawed, they look like this because they don't have the cells anymore. We need sperm, and we have to inject the sperm in because the sperm doesn't have kind of a map to get into the egg. That's called ICSI. And then we need to grow them in the lab over a week. This is actually the journey through the fallopian tube, because when we actually conceive at the end of the fallopian tube, it takes about a week for the embryo to come back in. And so that's what those the cell divisions are going on through the days, and then they get to day 5, 6, 7. This was also not possible when I was in fellowship very much, and now it's standard. Good labs can get a lot of these embryos through this stage, but only about half of the embryos will progress through these stage. So after fertilization, many of them drop off because they were never meant to be the baby that month. But we give them the best chance possible. In our tools, too, within our electronic medical record system, which gathers from tens of thousands of cases, we're able to actually calculate the probability of producing usable embryos from those eggs. So usable means euploid. Euploid means we have 46 chromosomes, boy or girl, like that the chromosomes actually separated properly and combined with the sperm chromosomes in a correct amount. So here we have again that 34-year-old. So you can see we make a lot of beautiful euploid embryos once they get to this stage when we're younger. And it's here right around 34, 35 that starts to decline and significantly decline over time. So theoretically, a 44-year-old would need 8 embryos in order to create one. And that's if probability actually plays out. Down here is just another way of looking at it in terms of the typical 34-year-old that comes to see us. Typically, they'll have about 16 eggs, 12, 13 are mature. How they fertilize, how they become blastocysts, like you see about a 50%, and the number that are actually usable because those chromosomes separated and recombined correctly. So where you freeze your tissue is really, really, really important because the technique and making sure the embryologists are really good at what they do is going to affect how those tissues behave later. And this is something that as a consumer, you have no idea. I have no idea until I really was able to work with RMA and see the quality assurance that they built in their labs. And part of that is because RMA is a huge network within the US, so they can constantly monitor and share ideas and quality assurance across labs. We have 2 sites in Seattle, but they're all over, and we really benefit all from the collection of that data. These are the embryologists that I get to work with. And so I told you about the people that I work with because that's actually how quality work is done. If there's a lot of good happening with the team members, it's going to translate to patient care. Their patients are embryos and eggs. My patients are people. And so Karen and I started the University of Washington program together, and I just couldn't wait to work with her again. So when we built our lab, we hired her 6 months before the lab was open so that she could be ready to go. She trained Maddie, and they are partners in the lab, and it's just amazing to see their work. This is a real-life blastocyst that they grew. you can see how beautiful this embryo is, about 300 cells. This embryo wants to implant. So we're either going to freeze it, or we're going to thaw it, or keep it in that situation and put it in the uterus because it's ready. Decades of experience between Karen and myself and the rest of the team. And then we have this beautiful lab, which is built on national and international standards. And this is just a small number of cards that I sometimes late in the evening, if I'm at work, will just pull out and read, because the work that I do is really meaningful. Sometimes it's because it's a patient we got to know early on in their career, and they come and trust us with egg freezing. And they come back. They could be living in Missouri, but they had such a good experience with us that they make the journey back to create their embryos and family. So particularly, I think for our young patients and people who are busy with their work life, we focus on making it easy. Our hours are very early in the morning, maybe a little too early for you tech people. 7 a.m., we're like, come on, let's get the data. And then we really do try to work very hard to make sure that we fit our treatments into your work life so that it doesn't disrupt your workday. Okay, and with that, I will take questions.
So we have a lot of anonymous questions also coming in.
Sure.
We circulated some sheets earlier. If you have any question that you want to ask anonymously, please bring those sheets to me. Deepti, can you help circulate, collect it from there? And since you have a question, you can go ahead.
Hello, thanks for sharing the knowledge. I think it's very helpful. It's my first time to learn so much. I'm wondering, because I've learned, let's see, based on my very limited knowledge, I've heard for each lady we have a certain number of eggs we have. And I'm wondering whether doing some egg freezing would speed up aging and also makes the menopause earlier. Yeah, so that's my first question. The second is, what's the pros and the cons? We know pros, and what's the cons?
Okay.
Yeah.
Those are excellent questions. And if I didn't cover that as I was explaining physiology, we have about 1 million eggs, right, when we're born. We have 1,000 when we hit menopause. And every month in between, we lose them. So the month that you come in to freeze your eggs, that entire crop of eggs would have been wasted anyway. They don't get to repeat the process. You would have a winner, and you'd have the rest of the crop would be losers, and no opportunity to ovulate, and they get absorbed back in the body. So with egg freezing, what we're trying to do is to give everybody a chance to finish the race that month. Meanwhile, the ones in the waiting area, the ones in the reserve, they don't have receptors to be able to respond. I mean, I've taken care of so many patients that I do see that sometimes cycle to cycle or month to month, there can be some variability. And I typically see that with egg freeze patients who have low ovarian reserve. So they come in, they don't have an AMH of 2, their AMH is low. We only see 5 or 6 little follicles to begin the cycle. We do an egg freeze cycle, we freeze 3 mature eggs. Next month, we spin again, and all of a sudden we get 9 eggs frozen. We do it one more time and we spin again, and it's 15 eggs frozen. That's much more likely to happen in a young patient, because I like to use this analogy. If you have a race going on and someone wins and your audience is really screaming and cheering, and now the next heat of runners is in the locker room and they hear that, they come on, they're like, oh yeah, we're gonna win. More of them run faster and we get more. And then the ones in the parking lot are even affected. But if you're 39, 40, there's not that many waiting to come through. And so typically, sorry, I'm on call. Typically, it doesn't happen as much with the older patients. So you do not spend your future supply. In a similar way, guys, if you're on birth control pills, you know how you stop ovulation? You can't extend your reproductive life into your 70s either. Because behind those birth control pills, waves of eggs are coming in trying to compete but the track is closed to them, so they don't even run. And so they just go away. So that's all kind of the biological clicking timeline. Pros and cons. Okay, we have some pros, right? And I learn about the pros from my patients every time because they tell me what they come back to use their eggs for. The cons are who comes back and what do we know? We've been freezing eggs now as a more standard way, open to all patients, non-experimental since 2012. Early on, very few people did it. Now more and more people do it, so we have more data. Somewhere between 16 to 22% of patients will come back and use them. But it's going up because more people are freezing. So more people are coming back to use the eggs in creative ways, whether it's to have their first baby or to have their third baby because they have 2 boys and they want a little girl and they want to try to create that little female embryo. So a lot of different ways that people come back. The other cons would be fitting this in your busy life, and also having to inject medications for every night for about 2 weeks. But generally, people get pretty good at that. The injections we ask people to take are very, very small. They're almost like insulin syringes, tiny. And the medications are really easy to mix once you get good at them. And we're always available for questions. So the other cons is that if you're a patient who perhaps going to a clinic that isn't watching you as carefully, you could get quite sick from this, something called hyperstimulation, because our bodies were designed to react to hormones from one egg ovulating. Now we got 20 eggs ovulating, 50 eggs ovulating. That's a lot of hormones swimming around in our system. And so there can be some pretty uncomfortable side effects to that, like a lot of bloating, things like that. I usually tell my patients, if we're very careful about it, you're probably going to just wear your sweats for a week. Like you're not going to want to put the skinny jeans on. And I tell my staff, if they come back for their follow-up visit in their skinny jeans, they're fine. Okay, they're going to be okay. So mostly it's just a little bit of bloating and just kind of getting through those first few days till the hormones come off. What else? Well, I think in this day and age, embryo freezing is an issue in some states as this political climate changes. So more and more we're thinking, eggs are really your most liberal tissue, if you want to think about it. You're the only person that's going to own that tissue, and there's less risk that outside opinions can affect how we use tissue that is just 23 chromosomes as opposed to 46 chromosomes. The last con I think would be, again, related to waiting too long. When the egg freezing first came out, there were a lot of women's studies. In fact, the women's studies department at Yale came out with a really strong statement of, are we encouraging our women to just keep working and not focus on balancing family life and other things? Are we making them into sort of monochromatic driven people? So that was some of the arguments in the beginning. But now more and more people are really just using it as a way to have that option later on. And more companies are offering it, which I think is amazing for people to not have to worry about the cost. Great questions.
Thank you so much, doctor. So I have in my hand more than 15 questions right now. I'm sure these are all great questions and it's a very important topic. If it's possible to extend a bit of time.
Yeah,
let me know.
I would be really very happy to extend the time. And then if you guys are, I'm happy to answer the questions now. I'm also happy to take these questions and what we can do, whichever ones we are not finished, I can do a little video and you guys can upload that on your website.
That would be amazing.
Okay, so, this way.
Yeah. I think that way everyone's questions are answered.
Yes.
And yeah.
And I'd much rather speak to you than type. That's what I tell my patients. Please don't make me type into the portal. Like I'm old fashioned. I might just call you.
No, I think that's better. And people also kind of want to hear it from you.
Yeah.
So what we can do is we can So we have a music show planned.
Yes,
We can do that and come back to this. This is easily going to take 45 minutes.
sure. Yeah.
So we can come back to it because people really want to kind of like, understand and dive deeper. So if you're okay with that, we can do the music program and then come back to our Q&A.
Absolutely. Be very
Thank
happy
you.
to. And you guys, this is where you find me, okay? I'm at, RMA New Jersey, RMA Bellevue, RMA Seattle. We have the ability to just bring you on and really talk to you personally about your goals and help get you set up so that you have a great cycle and plan it during a time that makes sense for you.
Yeah.
Okay?
Are you visiting both Seattle? So for the audience, are you visiting both Seattle and Bellevue clinics? Okay,
Yep.
awesome. And if folks were to come in for a consultation, what does the process look like? Do they reach out to you or do they reach out to?
Okay. Logistics.
Yep.
So go ahead and search us out on the internet. Google us RMA Bellevue, RMA Seattle, and there's a number there. You'll go through a central scheduling system because they're really good at getting your insurance information down, your demographics. They'll explain to you how to onboard. I've been doing telehealth since 2014. So our first appointment is completely remote if you like. Okay, you can always come in and see me, but I just mostly sit at the computer and talk to people. And then we start figuring out how to consolidate the testing. So we don't want to pull you in 17 times to get the blood tests and the testing that we need. So we usually try to do that on one day. Seattle's open every single day, Bellevue's open every single day, and most weekends. And again, we try to do things early in the morning so that you guys can get to work. Please be ready when you call with insurance information, as well as think about or start looking at your benefits at your company, because a lot of fertility benefits has a first step of registering with the fertility benefits manager. Okay, something called Maven for the Amazon people. That's new. Progeny for other online. For other tech companies. Carrot is another one. And so just make sure that you're registered with those already because they have very set packages for certain aspects of the care. We're in the diagnostic phase. We're in the treatment phase. We're in the freeze phase. And so our financial counselors can also help you with that. When you make an appointment specifically at RMA, we request a $100 deposit for that new appointment, which is put on credit for you for any insurance co-pays and things like that moving on. It's not just an appointment reservation fee, but that's how we help to organize our schedule. And we know then that you're committed to coming in to seeing us. And like I said, our new patient appointments are oftentimes interdigitated between myself and Taylor or Paulina. And Dr. Keller is a new physician who will start April 1st. And she's older than me, wiser than me, hopefully. And so I have a wonderful team of docs to work with.
Thank you. Thank you so much, doctor. This was very helpful. And I think it's one of those topics that needs to be educated upon and logically reasoned upon rather than just kind of like hiding it at the back of your mind. So thank you for making it visible. Like I said, for folks joining us on Zoom as well as people in the room, I know we have a lot of questions and we want to make sure this is a very important topic. We want to cover all those questions. All right, so we are getting back to the Q&A and I know we have a great amount of questions. Dr. Kathleen wants to cover all of the questions and address our concerns in details. So what we are going to do right now is take a few of those questions, talk through that, and the rest of the questions, since we have the Capital One Cafe space available now to host events, we'll probably host one more in-person event just to make sure that we get an intimate space to talk about it and clarify in details. Does that sound like a good idea? Cool, awesome. So I'll give you this mic and I'll ask you a couple questions. Actually, you can pick anything from here. Go ahead.
I'm going to try to pick a couple of questions, guys. Maybe there's a theme, okay? And then I can... Okay, this one is about the finances. I am going to address that because I don't think we did talk about that enough, okay? Everybody has different financial coverage for this, whether it's from 0 coverage to 100% coverage through your employers, okay? So my advice to you is to call your insurance company or your HR department if you have an HR page and look up specifically fertility benefits. There are so many flavors of coverage that there's no way that we could even generalize just knowing your insurance company. So you do your first homework. I can say that most of you that work for Amazon, Microsoft, Expedia, these organizations, big tech companies, Google, Meta, they have benefits for fertility preservation and fertility. And it's usually through a benefits manager. So for example, if you work for Google, it's Progeny. If you work for Amazon, it's Maven. If you work for Microsoft, it's Progeny. And I like to think of these programs almost as like little stamp books at the carnival. Like you have certain benefits, and it's important that you are aware of what they are. So when you come talk to us, we can design the most beneficial program to take the most advantage of your benefits, okay? So that's the first thing. So start first by asking your HR or calling your insurance and understanding if there are fertility programs that you need to sign up for even before your first appointment. Our team will also guide you, but it'd be good for you to know that. There seems to be also a bunch of questions just about how many eggs do you get to freeze and whether anything happens to them over time. So we capture all of the eggs available in a particular month, most of which, as you know, will be wasted if you do not get pregnant that month. Of those eggs that we retrieve, the laboratory looks at them in the dish, like that picture, and then they will be able to select the mature ones. The mature ones are really identifiable because they have a little garbage dump of chromosomes. It's called the polar body. Remember I told you guys we got to separate the chromosomes? So those are called our mature eggs, and they will be frozen. Once those eggs are frozen, they're good forever. No biological degradation when they're being frozen at minus 160 degrees in the liquid nitrogen. Okay, so you will have to consider what to do with them if you don't want them, but they're there for you for the next year, for the next 10 years, for a second marriage, for some other thing that might be in the horizon. And I am hopeful that someday they're also a source of treatment for us as technology advances. Okay. Yes. Please.
Thank you. Earlier, I think through few websites I've seen where you can donate some of the eggs and then get to store the rest for free. So is there any legitimacy to those programs? Also, like, how would the donation and everything work out?
So I think the question is, like, what are the different ways that we can dispose of eggs or disposition of our eggs and embryos, these kind of things? Well, I'll address eggs first. These eggs belong to you and only you. And so unless you intended to donate them at the time that you created them, so let's say I do your ultrasound and AMH and everything, and we do pick a proper protocol for you, and I get 21 eggs and we freeze 16. Let's say you say, I'm going to keep these all for myself, but 5 years later you now have 2 children and you're like, I'm not sure I'm going to need those eggs, but my best friend has had trouble having a baby. I would like to donate half of them to her. If that's the case, that's possible, and what we would need to do then is to help you navigate through the psychological and the legal pieces to make that relationship healthy and set. Okay, there can be a lot of things we don't think about when everybody wants to do things out of the kindness of their heart, but we've got to project out and get our lawyers to also help us make sure that those relationships are legally sound moving forward. If you were to donate them anonymously, like what you're describing, so let's say you don't have any finances to freeze your eggs, okay, like you don't work for one of these tech companies or you don't have insurance coverage for it. Egg freezing currently is about $8,500. With medications, could be up to $10,000, $12,000, depending on how much medications you need. Medications are thousands of dollars because they are expensive and to make. So if that's the case, there are some agencies, and I call them agencies because that's what we typically identify, companies, organizations that help pair a donor with intended parents. They may do exactly as you said, offer up programs where you would not pay for anything. You would go through the egg, the stimulation, the injections, the egg retrieval. You would keep a certain number of eggs, and then the other eggs would go towards an intended parent. And those intended parents are usually the ones that are paying something for the medications and the cycle. And that's a lovely way to think about it if you're thinking you wanted to both do something altruistic, kind of like give eggs for people in need, as well as have the advantage of keeping some for your own. I'd discourage that if you're thinking about freezing eggs honestly for your own self, because even in my talk, like there's no way to predict whether we're going to get 1 embryo or 6 embryos. We can give you probabilities, but until that happens, until we thaw the eggs and make the embryos from them, until we put an embryo into a uterus and allow a woman to be pregnant for 9 months, we just don't know if we're going to get a healthy baby out of that. So my suggestion is keep things clean. If your goal is to freeze eggs for yourself, do the best you can, save the pennies in the bank, ask help from family, because believe me, your family's going to want to support you for this too once they understand this a little bit more. That's the best way, because you know that in that crop, let's say you come in May of 2025 and Dr. Lynn freezes eggs for you, those 16 eggs. The hope is that there's 1 baby in there. We just have no idea which egg will create that. We might create 4 babies from that 1 batch, but we just don't know. In the future, when you use the eggs, if your partner has terrible sperm or very little sperm, that's going to yield less embryos. So there's definitely some unknown. Does that answer your question? Okay. Okay, good. There's a lot of different flavors out there. The other thing, too, I want to warn you guys is in this field, there's a lot of misinformation and a lot of variety of information. There's many agencies and companies. There's a lot of involvement because this is a field where you really have to trust the people that you're working with, that we're walking a good line in your benefit, with your interest primarily. Okay, great. So those are a couple of questions, and I think that because there's such an interest for these, I spoke with Sarabi that I would be really happy to get together again with everybody. I can also try as a follow-up, I spoke with her about reading some of these questions and just answering them through kind of a video platform, and maybe we could put a link on that to today's conference. And so if anybody out there or in here had to leave and didn't have their questions answered, they can go back to that link, and I'm happy to address these questions, okay? But you guys are amazing, and this was a wonderful conference to be a part of, so I look forward to seeing some of you again.